Hello everybody, this is Carlos from Army of Nurses and welcome to another video. In today's video we will be covering the topic about blood transfusions. Some of the other topics that we will be covering in this video include the ABO group typing and RH factors, some indications for transfusions, cross-match versus and cross-match blood, nursing care, adverse reactions, massive transfusions protocols, and we'll talk about also quickly about some of the other blood products available for our patients. So the ABO category system that we use to categorize the blood type is the ABO system, and it's called ABO because they separate the red blood cells into the type of protein that they have on their membrane. So there is either two types of proteins. There's either the A type or the B type. AB just means it has both proteins, A and B, on their surface, and O just means it doesn't have any of the proteins on their surface. Now the RH factor is a separate factor which is also a different type of protein on top of the ABO system that it plays a crucial role when we're trying to decipher who gets blood, and if the patient might be pregnant or will be, for example, planning to get pregnant in the future. So something that we have to consider. So type A, as you can see here from my drawing, we just drew the red receptors as A type, and the little blue ones that look like a cone as those are B antibodies. As you can see, if you are type A, right? If you're type A, then your red blood cells, they have a type protein on the surface, and they cannot have a anti-A antibody, because in that case your plasma will be attacking your own red blood cells, and that wouldn't be a nice thing, right? So type A, people who have type A blood have anti-B antibodies in their plasma. Okay? Type B people have the opposite. So, like as you can see here, the B type protein, right, the blue one, then they cannot have B antibodies in their plasma, so they have anti-A antibodies. So in this case, you can see that the red ones, it doesn't fit in, so there wouldn't be a reaction. There would not be an autonomical reaction, so the body would not be able to attack itself. On people who have AB, type AB blood, that means that their red blood cells, they have both receptors on top, the A and the B. For the same reason, their plasma cannot have any type of A antibodies or B antibodies, because either one of those will react with the RBCs, with the red blood cells, right? So it will cause a reaction as well. Last but not least, the type O, as you can see, type O red blood cells, they don't have any of the A proteins on the surface, neither the B proteins on the surface. For this reason, plasma of type O, they have anti-B and anti-A, right? Because they don't have anything to bind to, so the plasma has all these antibodies on top. Now for RH factors, they are virtually the same thing. So we say that a person is RH positive when the cells, when the red blood cells, they have the RH protein on their surface. When they have the RH protein on their surface, their plasma cannot have antibodies. Same idea, right? Because it will cause a self-reaction. And on people who are RH negative, the cell, it doesn't have any of the RH protein on the surface, but the plasma will contain RH antibodies, right? Same principle. So just to summarize, So if your patient is of type O, right, then the patient will only be able to receive type O because type O is the universal donor, right? In the other hand, if you're type AB, then you are able to receive AB blood, type A, type B, and type O. So people who are AB, they are able to receive all the type of blood, and they are usually called the universal recipients. In the other hand, A and B, A can get type A, quite natural, right? And A can also receive type O, because remember, O can give to anybody. Same thing with B, can receive B and O as well. Now, this is the simplified version, okay? The more complete version is if we add the RH factor on top of it, and this is how it looks like. So same principle in here. One thing that you just have to remember is that patients who are RH negative, right, they can only receive negative type of blood. So if we take that idea into consideration, we already know that O is the universal donor, AB is the universal recipient, A and B obviously are just A and B, different type of proteins, right? So if we just go by that idea, and we can say that O negative, remember negative can only receive negative, right? Positive, in the other hand, can receive either positive or negative. So if your patient is O negative, then O is only O, right? But negative is also negative. So in that case, she can only receive O negative, right? If your patient is O positive, remember, patient is O type, then the patient can only receive O type blood. Now, if we add the RH factor on top of it, remember, positive, RH positive, they can receive negative and positive. Only if the patient is negative, they can receive negative only, okay? But if the patient is positive, they can receive positive or negative. Same here, A negative, so a patient can receive A and O, right? So negative can only be the negative version, so negative A, negative O, right? Same thing applies for A positive. Remember, A can get A and O, but positive can receive both, positive and negative, positive and negative. Simple as that. Next, we're going to talk about some of the indications for a transfusion, which is quite obvious sometimes, or sometimes it can be a little more insidious. Number one is excessive bleeding. It could be due to trauma. If you do end up working in a trauma center, you will see a lot of bleeding. Blunt traumas, patients who fall down from great heights, stab wounds, gunshot wounds, all those stuff. Surgery, usually if they have GI surgery, if they have, very extensive cardiovascular surgery, hip surgery, any type of surgery really, they have the risk of bleeding profusely. Gastrointestinal bleeds. These ones are a little more insidious because the abdominal cavity, it has so much free space inside that a lot of blood can be lost through the GI tract, and healthcare professionals might not be able to see them as obvious because there's so much space inside the abdomen that the blood just keeps filling those empty spaces until it's too late. Right? Until the patient, obviously starts to vomit blood, becomes tachycardic, hypotensive, and bleeding starts to go from internal to external, then that's usually a very, very late sign. Another reason for excessive bleeding, postpartum. Patients who have cesarean sections or emergency deliveries, they're also at risk of having excessive hemorrhage due to that. Another reason for transfusions, anemia. either acute anemia or chronic anemia, and also a low hemoglobin, that could be caused by, patient being critically ill, by the patient bleeding, or the patient's anemic, so any of the above. So it is worth mentioning two types of blood. One is called the cross-match and the other one is called the uncross-match. So all it does is uncross-match, all it means is just that there's no test done to ensure compatibility with the recipient. And you might ask, well, but that's kind of dangerous. Yes and no, right? So in the sense that it is dangerous in the sense that you want to obviously always check for full compatibility, but in the other hand is usually used for emergency situations where patients are bleeding profusely and you need to get blood into them right away. So uncross-matched blood, obviously is type O, like we mentioned earlier, because type O are a universal donor, right? So that means that anybody can get type O. Now, the thing gets a little more complicated when it comes to the Rh factor, because if you do have a trauma patient, you have a female, for example, that comes in 30 years old, and was involved in a motor vehicle accident, and you see obvious signs of bleeding, is hypotensive, tachycardic, all those signs of shock that you can see, right? For females who are on childbearing age, right, we want to make sure we give them O negative. And the only reason is because we, at the moment where we're treating that emergency, we don't know if the patient has had a previous pregnancy with an Rh positive partner, right? So, and that will cause hemolysis of the blood, and that wouldn't be good. So, females in childbearing age, if it's an emergency, O minus, okay? So type O negative. Men, doesn't matter. O positive, O negative, doesn't matter because men cannot get pregnant, right? So cross-match, it just means the opposite, that we have taken the time to send for a type and screen, and the laboratory has taken their time to run the test to see the compatibility, the type of blood, and to see if there's any antibodies that might have been developed in the plasma. Next, we're going to move on to nursing care and procedures. We're going to talk about 3 stages: the pre-transfusion, so before you start your transfusion, while you're doing the transfusion, the intra-transfusion, and after the transfusion. So for pre-transfusion, one of the things you always want to see is make sure you want to check the physician's order. You ensure that the patient has an informed consent sign, that all their questions and concerns have been answered by the healthcare team regarding all the benefits and obviously all the potential risk involved with the transfusion. Only in cases of an emergency where the patient is unable to give an informed consent and there is obvious sign that if blood is not delivered to the patient in this circumstance, it will cause dire consequences, then that's when the physician might override the consent, because there's an implied consent that governs due to the situation, the emergence of the situation. Right? We always want to ensure that the patient has a correct ID band on, because those ID bands, sometimes they fall off, they wear off. It happens, So you always want to make sure if they don't have an ID band, you put one on, and if it's worn out, you always want to make sure you put a new one on, and you double confirm the patient's identity with the patient if the patient is alert and oriented. Or if there's family on the side, just confirm patient's first name, last name, date of birth, and match your hospital number with the chart number to ensure that you've checked the patient's identity properly. Send blood samples for cross and typing again, and the number of units that you require, just to see the patient's ABO grouping and if there's any antibodies in the plasma. Enter the order in the computer or call the blood bank. Some hospitals, the nurses have to do this, and some hospitals have the luxury of having a unit clerk that's able to enter the orders in the computer. Ensure that the patient has a large IV, preferably in the AC or a vein that is larger. If you're unable to get that, then you work with what you have, right? So always try to go for a large bore IV if that's not possible, because usually people who need a blood transfusion, they are either dehydrated, hypotensive, so veins might not be as prominent, and it might be difficult to find veins. So you work with what you get. Also ensure that if you do get an IV on a patient and you need to run blood through that, do not wire the connection, which what the meaning of wiring is, you split the IV line into two lines and you run one thing in one side of the Y and another thing in the other side of the Y. For blood, try to have a dedicated IV just to ensure there's no reactions, okay? Then we need to set up the tubing. Make sure that the IV tubing has a filter in it. The filter's purpose is to filter any bacteria that might have sneaked in into the blood. Okay. Always flush it with saline, normal saline, 0.9 only. No D5, no ringers, no 2/3 and 1/3. NS only. And before you start, it's always good to obtain a baseline of your vital signs, including temperature, just to see if there's any changes. Then you can pinpoint where the cause was. In this case, it could have been the transfusion. So intra-transfusion. Now that the transfusion is going, you check all those stuff from the pre-transfusion. You always perform a health assessment. It's always good to do a head-to-toe. Make sure your patient's alert and oriented. Ask them if they have shortness of breath, chest pain, back pain, if they're just feeling unwell, any itchiness. Sometimes it's so hard to tell the patients all the symptoms that they might experience, because not everybody feels the same symptoms, number one, right? And number two, they might not feel anything. So usually what I find is, when I tell patients that if they feel anything unusual, to call the nurse, right? Because it's when we tell patients, to look for, shortness of breath, back pain, this and that. So patients become so fixated, looking at those things, although those are the things that we want to look for. But when you tell a patient, if you start feeling unwell in any way, let the nurse know. And, you are going to be on the bedside when you are doing transfusion. So you will have a you will have an objective, assessment of the patients, and the patient will give you their subjective, assessment, how they're feeling, if they're having pain, and so on and so forth. If you do encounter a reaction, no matter how minor, the patient's having itchiness or having hives and stuff, stop the transfusion right away. That's your number one thing that you're gonna do, no matter what. So stop your transfusion and maintain the IV line with saline. And you call the physician and the blood bank, to let them know that the patient's having a minor or just a reaction to the blood. If no reaction happens, then you monitor their vital signs every 15 minutes after the initiation of the transfusion. So once you initiate your transfusion, you check your vital signs before you start, 15 minutes, and you use your judgment, as in how often you need to do your vitals. So once the transfusion is done, of course, we need to assess the patient again. Do your head to toe. Focus on listening to the chest. Make sure that patients don't have crackles. Make sure patient doesn't have any visible signs of distress. If usually everything goes well, patients will start to feel a little better. They always, most of the time, they tend to say they feel less fatigue. So you continue to monitor the patient, because some reactions can take a while to develop, up to 6 hours or more. You keep the transfusion bags once the transfusion is finished with you, just because if the patient does develop that delay reaction, you have to send that back to the blood bank so that they can do some investigations. But after a few hours, if the patient is completely fine, then you can discard that in the proper containers. Please don't throw that out in the garbage, because those are blood products, right? You always ensure you maintain an IV with normal saline, and you need to repeat your blood work as needed. Sometimes doctors don't need to order the blood test, because they'll just do it with the next morning blood work. In other areas, like in the emergency room or in critical care, acute care areas, doctors will usually write a standing order to check for CBC after the blood has been given, so that they know where they're standing of if the patient needs any more blood or not. So in an unfortunate event that your patient develops an allergic reaction, right? So some of the things, or some adverse reactions, so these are major and minor mixed together. So itchiness is one of probably the most common. You have to check for fever, because that could mean that the blood could be contaminated and patients developing an infection. If they're becoming short of breath, either just they have decreased air entry, or they have crackles in their lungs where they weren't there before, stop the transfusion right away, because they could be leading into TRALI, which is transfusion-related acute lung injury. And one of the ways, is the patient will develop severe respiratory distress. The chest is gonna sound congested, crackly, decreased air entry, and the patient will be hypotensive. So if you see that, then call the doctor right away. Back pain, anaphylaxis, sometimes because of the the ABO type grouping, sometimes, it happens that the patient develops an allergic reaction to the blood. So you have to watch for that, because the anaphylaxis can lead the patient to go into shock due to the massive release of histamines that causes the dilation, right? So you lose your pressure. And sepsis obviously is another source of shock, due to bacterial infection or contamination of the blood. And hemodynamic instability, you want to make sure that you monitor your patient's vitals quite frequently. That's why we say the intra-transfusion, before you start your transfusion, 15 minutes, and then every hour if the patient's doing okay, and PRN, as needed, based on your judgment. And that's because a patient can go into something called a TACO, all right? So a transfusion-associated circulatory overload. So patient will become obviously short of breath, and might hear crackles and all that stuff. But in this case, the patient will be very hypertensive, because they are fluid overloaded. You might see a jugular vein distension and everything related with volume overload. So that's something that we should definitely keep an eye on. Next, we're going to talk about the massive transfusion protocol. So some hospitals have this, and I think it's a great thing, because it allows to a quick response to patients who are losing blood very quickly. So it's activated when massive blood loss is evident or suspected, because remember, external bleeding is quite evident, but internal is very insidious, right? So type O red blood cells and type AB plasma when the type and screen is unknown. So going back to our ABO typing, remember O, right? The O cells, because they don't have receptors, the cells themselves, they can be given to anybody. O is the universal donor. Now AB, the plasma, but not the cells, AB plasma, they don't have any antibodies. Remember, because the AB cells, they have the A and the B proteins on the surface, so the plasma cannot have any of those antibodies. So therefore, AB plasma is a universal plasma. Okay? And for massive transfusion protocols, they usually include 6 units of PRBC, 4 units of 4 units of fresh frozen plasma, I'm sorry, and 1 unit of platelets. But you know what, different institutions, they have that number might change ever so slightly, but you want to give them blood, you want to give them some plasma so that they have the electrolytes, so that they have the factors, the anticoagulation factors, and all those stuff. And the platelets, obviously, you know, you want the platelet cells to be able to form a stable clot so that they stop the bleeding. Some institutions, you know, have the advantage of having a level 1 infuser and warmer, and looks like this machine. So all this machine does is it puts pressure. It pressurizes, it warms for fast delivery of blood or fluid. So you put either saline or blood here, saline and blood here. You turn on the pressure, and assuming the machine has been has all gotten ready and primed and everything, then it delivers fluid at a very, very fast rate, which is very crucial for very severe traumas or very serious GI bleeds. It requires extensive training as an add-on skill. And usually for the rate is actually quite impressive, because for red blood cells, for PRBCs, it can go up to 150 cc's per minute. So you can run your unit of blood in a minute or two. And that is very, very fast, right? For crystalloids, in the other hand here, then you know, it can go anywhere from 200 cc's a minute to half a liter in a minute if required. And of course, what dictates the rate of this will be the size of the cannula. If you have, for example, number 20 IV, then you cannot really go that fast, because your cannula is so small that you can only push fluid at a maximized rate. But if you have an IV that's a size, let's say 16 or 14, for example, then the gauge of those cannulas are quite large, and you can actually push quite a bit of fluid quite fast through those. So the size of the IV, it does matter when given massive transfusions protocol. It is worth to mention some other blood products. We did mention this before. So fresh frozen plasma, contains your electrolytes, serum proteins, coagulation factors, antibodies. Platelets are your pool of platelet cells to help agglutinate and form a physical clot. And sometimes we give patients cryoprecipitate, because if they have a very low source of fibrin, then the coagulation cascade, it doesn't work properly, and the patient cannot form stable clots. Also, some other medications that could be used for to create blood clots is tranexamic acid, and it's usually in traumas or massive transfusion protocols, for patients who are bleeding massively. And yeah, so it's always good to be able to know all your blood products, and when the patient is having a reaction or not, because blood, it does save a lot of lives. So this concludes this video. So please donate blood when you do get a chance to in your local clinic, because it helps everybody. And like they say, blood is in you to give. Okay, thank you very much. That's it for this video. If you like this video, please like and subscribe, and I'll see you next time. Thank you very much.